So, next up we have aztreonam. Aztreonam is a monobactam that inhibits cell wall synthesis. So some of the benefits of its use include synergy with aminoglycosides and the absence of any cross-reactivity with penicillins, which means that it has utility in patients with renal insufficiency and penicillin allergy. It also tends to have very few side effects. On the flip side, aztreonam has limited utility, as it is only effective against gram-negative rods, so you're less likely to see a question on this antibiotic, and I'm not going to spend much more time on it. Let's talk about carbapenems. The great thing about carbapenems is that they have a very broad spectrum. In other words, they cover a broad range of bugs. Imipenem is a carbapenem with broad spectrum activity and resistance to beta-lactamase. It is always administered with cilastatin. I've spelled these out for you. Imipenem is administered with cilastatin. Note that cilastatin, although it has the word statin in it, is not a statin. It actually inhibits renal dehydropeptidase 1, thus decreasing the drug's inactivation by renal tubules. The mnemonic, the killer's lastin with cilastatin, can help you remember this. Meropenem is another carbapenem that does not require co-administration with cilastatin. These drugs are effective against gram-positive cocci, gram-negative rods, and anaerobes. Ertapenem is a newer carbapenem that has limited Pseudomonas coverage. The carbapenems in general are typically restricted antibiotics and are reserved for particularly resistant organisms and life-threatening infections. Imipenem in particular has a side effect of causing seizures at very high plasma levels. That's not something you really want to administer without due caution. Now, let me ask you, have you heard of CRE? It's been in the news a lot lately. These days, the major concern is for carbapenemase producing rods, such as enterococci. The reason infectious disease doctors are concerned is because our antibiotic armament against these organisms is extremely limited. Now, let's move on to the next antibiotic that acts on the bacterial cell wall, vancomycin. Vancomycin is only active against gram-positive bacteria, but it has particular utility against Staph aureus. We already mentioned it. It is first line in MRSA, or Staph aureus species that are resistant to nafcillin. This image shows a cutaneous abscess that was then shown to be caused by a methicillin-resistant strain of Staph aureus. Now tell me, can you tell that it's MRSA just by looking at it? Well, no, of course not. You would find that out by culturing the wound and or the patient's blood. Note that vancomycin is also used to treat C. difficile infection. C. difficile is the organism that causes pseudomembranous colitis. However, the difference is that it is used in an oral form rather than the IV method that is used for all the other indications for vancomycin. Basically, C. diff infection is the only time you would use an oral formulation of vancomycin. The classic toxicities associated with vancomycin are nephrotoxicity, ototoxicity, thrombophlebitis, and red man syndrome, the latter of which is seen more frequently with rapid infusions of vancomycin. So, if you see a patient flushing red after being treated with vancomycin, you'd want to first stop the infusion and then administer an antihistamine such as diphenhydramine, which is also commonly known as Benadryl. Another name for the rash is erythroderma. Note that this is an anaphylactoid reaction. If you aren't sure what that means, I would go back and refer to immunology for clarification if you need it. Now, let's talk about how vancomycin functions and how bacteria develop resistance to it. In this image, vancomycin is the blue molecule. You can see here in this image that there is a D-allo-D-allo moiety on the end of the peptide chain. Just double check the key if you aren't sure what I mean. But basically, there are two alanines on the end of the peptide chain. So, as you can see in this image, vancomycin, which is the blue molecule, binds to the D-allo-D-allo portion of cell wall precursors. It thus functions as a bactericidal antibiotic that inhibits cell wall peptidoglycan formation. Now basically, resistance occurs when there is an amino acid switch of D-allo-D-allo to D-allo-D-lac. You can see here that the D-lac is this pink square, so we've changed the D-allo-D-allo to D-allo-D-lac in this image. This is the site on the cell wall precursor where vancomycin normally binds. Now you can see in this image below, basically, there is a change in the peptide that affects the binding of the antibiotic. Before I move on, I'll quickly mention bacitracin. It also acts on the bacterial cell wall. It is used topically and forms part of the commonly used ointment Neosporin, which you can buy in the pharmacy. It can be used for certain skin infections. Another flash quiz. So, vancomycin resistance develops when which amino acids switch to which other amino acids? What is the consequence of the switch? Vancomycin resistance develops when the D-allo-D-allo amino acids switch to D-allo-D-lac. This disrupts how vancomycin normally inhibits cell wall peptidoglycan formation. Now that we are done with that entire group of antibiotics that target the cell wall, we're going to talk about the antibiotics that target protein synthesis. Bacterial ribosomes are targets for antibiotics. Do you remember what the different sizes of human versus bacterial ribosomes are? Right. These antibiotics are selected for the smaller 70S bacterial ribosome and do not affect the 80S human ribosome or its ability to synthesize proteins. I've written that for you here. 70S ribosome is in bacteria, while 80S is found in humans. Recall that the 70S ribosome subunit of the bacteria is made up of a 30S subunit and a 50S subunit, each of which is a target for antibiotics, which I've summarized here. Aminoglycosides and tetracyclines both inhibit the 30S ribosome. Inhibitors of 50S are chloramphenicol, clindamycin, erythromycin, and linezolid. The mnemonic bi at 30 and cell at 50 is helpful for remembering which antibiotics affect which subunit. The at 30 mnemonic is supposed to help you remember that aminoglycosides and tetracycline inhibit the 30S subunit. For the 50S subunit, the cell mnemonic stands for chloramphenicol, clindamycin, erythromycin, which is supposed to represent the entire macrolide group, linezolid, and lincomycin, which is a very low-yield antibiotic that is related to clindamycin. Out of all of these, linezolid acts a little differently because it prevents the initiation step of protein synthesis, whereas most of the other antibiotics that inhibit protein synthesis inhibit elongation. Alright, first we're going to talk about aminoglycosides. So, the aminoglycosides include gentamicin, neomycin, amikacin, tobramycin, and streptomycin. I'd advise you to try to remember these drug names because you'll notice that the macrolides, as well as vancomycin, also end in the name mycin. So you're going to benefit from remembering these and that they are aminoglycosides. Aminoglycosides are bactericidal and inhibit the formation of initiation complex and cause misreading of mRNA. Remember that A initiates the alphabet to help you remember that aminoglycosides affect the initiation complex. Because they require oxygen for uptake, they are ineffective against anaerobes, but they are effective against aerobic gram-negative rods such as Pseudomonas and facultative gram-negative rods such as E. coli, which is shown in this image. I like to remember that aminoglycosides need oxygen. Aminoglycosides are notable for their nephrotoxicity, which is worsened when they are co-administered with cephalosporins, which is a fact that I mentioned to you before. They also cause ototoxicity, which is exacerbated when used with loop diuretics such as furosemide. Importantly, they also have teratogenic potential and should be avoided in pregnant women. Okay, next up we have the tetracyclines, all of the names which end in cycline. Basically, tetracycline, doxycycline, and dimiclocycline, as well as minocycline, are all bacteriostatic tetracyclines that bind to the 30S subunit of bacterial ribosomes and prevent the attachment of amino-acyl tRNA. They need to be taken carefully because calcium, iron-containing products, and antacids affect their absorption. This is because tetracyclines are chelators of calcium and iron. Because of their ability to accumulate in cells, these drugs are particularly effective against intracellular pathogens such as rickettsia and chlamydia. This is an image of Rocky Mountain spotted fever, which is caused by rickettsia. Now, you may be wondering, how might I know this? That's right, because the rash covers this person's palm. Remember that Rocky Mountain spotted fever causes a rash on the palms and soles. Tetracyclines are contraindicated in pregnancy because the drug can cross the placenta and cause discoloration of teeth. The classic side effects of tetracyclines are teeth discoloration in children, which is why they aren't used in children, as well as photosensitivity. One last point about tetracyclines. Dimeclocycline is a tetracycline that isn't really used as an antibiotic. Because it also acts as an ADH antagonist, it is used to counter the effects of SIADH. I would go to the endocrinology section and learn about SIADH if you are not sure what I'm talking about. Macrolides are next. There are 3 macrolides, namely erythromycin, azithromycin, and clarithromycin, which inhibit protein synthesis by blocking translocation. Think about macroslides as a mnemonic to remember that they block this translocation. These bacteriostatic antibiotics bind to the 50S ribosomal subunits. Macrolides in general are used to treat atypical pneumonias, such as those caused by Legionella, which is depicted in this image here. They are also used to treat upper respiratory infections, sexually transmitted infections, and streptococcal infections. They are useful alternatives when a patient is allergic to the penicillin family of antibiotics. Some adverse effects can be summarized with the mnemonic macro. Gastric motility issues, arrhythmias as a result of prolonging the QT interval, acute cholestatic hepatitis, rash, and peripheral eosinophilia. An interesting fact about macrolides is that they accumulate within leukocytes, which then conveniently transport them to the site of infection. Also remember that erythromycin is a cytochrome P450 inhibitor. Go back and take a look at pharmacology to review the activators and inhibitors of cytochrome P450 to solidify this information in your brain. I want to help you drill this in because this will be important both now and down the road when you enter the wards. Here's a list of antibiotics. Pause the slideshow and take a moment to sort them out into the appropriate class of drugs. Notice that because I'm trying to confuse you, all of these end in mycin. I've listed out the antibiotics according to their group on this slide. Remember that gentamicin, neomycin, amikacin, turbamycin, and streptomycin are all aminoglycosides. Azithro, clarithro, and erythro are the macrolides. Vancomycin is in a separate category and is a cell wall inhibitor. Both aminoglycosides and macrolides are protein synthesis inhibitors, but aminoglycosides target the 30S subunit, while macrolides target the 50S subunit. Alright, now I'm going to continue with the rest of the protein synthesis inhibitors. Chloramphenicol is next. It is a bacteriostatic drug that inhibits 50S peptidyltransferase activity. It is classically used to treat meningitis, but it has limited utility when other options are available due to numerous toxicities. It's mainly used in developing countries because it's cheap. One of its side effects is in infants. In infants, chloramphenicol cannot be metabolized because they are lacking liver UDP glucuronil transferase. This results in gray baby syndrome. Chloramphenicol is also associated with anemia, which is dose-dependent. In the image on the top, you can see microcytic hyperchromic anemia. Chloramphenicol is also associated with aplastic anemia, which is dose-independent. In this image on the right, you can see this hypocellular bone marrow, which largely is comprised of fat. If you're shaky on this concept, go back and review this topic in hematology. Clindamycin is bacteriostatic by blocking translocation at the 50S subunit. It is effective against anaerobic infections such as Bacteroides fragilis and Clostridium perfringens. Do you remember which disease results from the use of clindamycin amongst other antibiotics? This image is trying to give you a clue. That's right. One of the most important implications of clindamycin use in the clinical setting is the increased incidence of pseudomembranous colitis as a result of C. difficile overgrowth. In this pathology image, you can see a mucopurulent exudate that erupts out of the crypts in the colon to form a mushroom-like cloud of necrotic debris and neutrophils overlying a denuded epithelium. Remember, in these pathology images, neutrophils are blue-colored. If this is unclear to you, I would go back and review your pathology notes. Now, do you remember what is the other antibiotic that commonly causes C. diff? That's right, it's ampicillin. However, I will emphasize this. Remember that any antibiotic can cause pseudomembranous colitis. It's just that clindamycin and ampicillin are used so commonly, so they commonly cause pseudomembranous colitis, and so they like to test these two antibiotics. You can treat PMC or pseudomembranous colitis with metronidazole. I would remember that anaerobes above the diaphragm, such as in the lungs, are treated with clindamycin, whereas those below the diaphragm, such as in the GI tract, are treated by metronidazole. I've made a diagram of this for you. I know it's a really bad diagram, but I'm trying to illustrate that anaerobes in the lungs are treated with clindamycin, while anaerobes in the GI tract or below the diaphragm are treated with metronidazole. Let's briefly talk about linezolid. It is a restricted drug that is active against gram-positive organisms. You'll see it used in the clinical setting for cases of MRSA where vancomycin cannot be used, or in the case of VRE, or vancomycin-resistant enterococci, which are exactly as they sound, enterococcus that has developed resistance to vancomycin. These last two drugs are used in combination to treat infections by staph as well as VRE, similarly to linezolid. They're not very high-yield drugs.